All right. Welcome to another episode of the Narula series featuring a great shock and shockwave case. We've got Arvin Narula here. He's got a great case to share, some good conversation, hopefully. So, Arvin, kick it off, buddy.
So here's a case where we have a pretty sick patient. He comes to a small community hospital without surgery on site. So this is one of these cases where we see it quite frequently. A patient comes in, he's 72. He has a history of tobacco use, hypertension, prediabetes, and he comes in very sick. Acute onset chest discomfort in the emergency room. His vitals look like he's pretty unstable. Blood pressure 71 over 59. He's uncomfortable. The ER calls me, says that there's ST elevations in the lateral leads, and they're starting epi. So this is kind of one of these scenarios where I'm like, oh, this is when you want all the tools to your disposal. But
And I
sometimes,
think Arvin, the other interesting thing is it's always in the small community centers without on-site surgery that you get the sickest patients, right? Because
oh,
they're
absolutely.
they're in rural places. They present in shock very commonly. We've got one of those centers in Idaho, and it's such a conundrum because you have less tools available and the patients are sicker. So it's a tough situation to be in.
Sometimes these later presentations are pretty tough. Yeah. So here's the angiogram for this patient. Again, it was a lateral STEMI presentation. So it looks like the left circumflex, the culprit here. And then it looks like also there's some pretty nasty eccentric LAD calcification
Yeah.
and a good amount of collaterals to the right. So um, again, here kind of highlights the LAD showing that eccentric calcification and collaterals to the right. And the RCA looks like it's a CTO basically with some integrate flow or collateral flow supplying the distal.
And Arvin, what's this guy doing right now while you're doing the angiogram?
So
Is he
he's pretty
getting
sick. We're
sicker?
moving fast.
Is he maintaining the status quo in terms of being stably sick? What's his
He's
trajectory look like?
he's kind of uncomfortably stably sick is what I'll call it. So he's kind of at that blood pressure of 71 over 59. He's on drips. So if you kind of talk about National Cardiogenic Shock Initiative, I like to dip the LV. And then once I dip the LV, I found that his LVDP was 36 millimeters mercury. I knew his diastolic pressure was like 60. So that's a low coronary perfusion pressure. At that point, I tell my team, let's get this Impella in so we don't cope, basically. The,
Yeah.
the concern is now in these smaller programs, you don't have all the tools at your disposal. So I want to try to stay ahead of that shock spiral, preventing people from, coding, having VF. If you get there, then it's really, really challenging. So I put the Impella in up front. And this trick I learned is kind of nice. You take the 018 wire and you can kind of mark where the cusp is. And you can kind of tell if the Impella is too deep or too shallow. You can actually start pumping like this, which is kind of nice. So
No, I
this is
love that, dude.
this is a nice thing, and I like to do this again to kind of have my case go a little more smooth. That way, I'm not doing CPR during balloon inflations or whatnot. So I think this was the right case for that. You knew his RCA was out, you knew his LVDP was super high, and you knew he had multi-vessel disease with a culprit of the circ, and then also LAD disease on top of everything.
Yeah, dude, I totally agree. And I think, a lot of people like to do swans to guide decision for hemodynamic management. But when you're at a satellite hospital that doesn't have a lot of tools,
Mhm.
Impella is the best you got. And this guy's sick. And I totally agree. The earlier you get that thing in, the better he's going to be. If you wait till after you fix the PCI or he crashes in the middle of the PCI, you're going to get way behind the curve. So I love that. Did you go single access or did you?
Uh, this one was not. This one was not single access. Just um, we had the reason I don't like to do the swan first is the neck is never prepped. So
Mm.
it takes me a while doing the leg swan. That's like my least favorite thing to do. The swan from the leg in a crashing patient.
Okay, Aiden Rainey taught me this trick. It's a great trick. You take a 6 French angled pigtail from the femoral vein. It goes straight into the PA, and then you just take an 014 300 wire and you swap it out. It takes like 2 minutes. It's super.
Got
It's
it.
super
Like
fast. If you're struggling.
like we do our P's.
Yeah, exactly,
Yeah.
exactly. So take me through your thought process in terms of what you're gonna fix, how you're gonna fix it. This guy's sick. Did he get better with the Impella?
So the thought process here is, yeah, he definitely got more stable with the Impella. At this point, I kind of paused, kind of have a little conversation with the nurse, talking about pressors, what the goals are, trying to get our map down actually, usually when the Impella initially gets put in place. So we're trying to wean off pressors at this point. That way we can kind of focus on the case and just do a solid job. the thought process here was there was an osteal circ culprit. So I didn't think I could just leave that alone, essentially, as well as the severe eccentric LAD lesion, supplying the RCA. So at that point, I thought I was kind of committed to a two stent strategy.
Got it.
So here we have just a compliant balloon um, around that circ, that troublesome circ area.
Yeah.
And again,
AP
this is where
man. It's the
we
bane
don't have,
of the cardiologist.
yeah, and because rota there's no surgery on site, there's no rota on site either. And this isn't the case that you want to do rota in either. In the STEMI presentation, shock presentation, having things go downstream is not ideal. So I always say we call it litho lament here when you don't use shockwave and you should. Um, so the balloon didn't expand. So lucky for us, we did have IVL balloons available. We had a 3 millimeter shockwave balloon. It's funny, the day before they actually used quite a few shockwave balloons on a different case. So the par, again, this is a smaller hospital, so the par levels of everything are kind of lower.
Mm.
So we didn't have a lot of stuff. So we ended up using a 3 millimeter shockwave balloon. I actually wish I kind of could have upsized and had a 4 millimeter balloon available and maybe just gone to 2 atmospheres. But this is kind of what we had at our disposal, so we used it.
Did you do the shockwave slide? How many pulses did you get?
We definitely did a few, and then kind of confirmed expansion with an NC prior to stenting. So here we kind of did we did DK crush here. Just comfort level, I guess, of choosing the left main strategy. And again, the patient at this point was pretty stable, and I kind of committed up front with 2 wires down already that we were going to use a 2 stent strategy here.
The Abiomed people push their device pretty hard, but I do think there's some good points that they make about Impella. I do think it gives you a little bit more leeway to do more complicated stenting strategies, right? So if this guy was still in shock and you didn't have an Impella in or you had a balloon pump, a DK
Yeah.
crusher would never work because it just takes too long. But with the
Yeah.
Impella in, I think it gives you time to do a good bifurcation. It
Mhm.
gives you a little leeway to do the shockwave balloons so they don't get too sick. And I
Mhm.
have seen it, dude. I mean, they show these videos where you have horrible flow in your coronaries and you put the Impella in and the flow gets a lot better. So I do think there's a lot of utility to an Impella, especially in the like acute kind of shock patients. So I totally agree.
Yeah, and then, during these inflations, because the right's out, there was loss of pulsatility. So
Got it.
yeah. Again, we do the shockwave slide, kind of move that 3 millimeter balloon back and forth. Again, I wish I had a 4 at my disposal to kind of oversize and then inflate at maybe a lower atmosphere. I kind of like that approach, but this actually worked pretty well. We ended up stenting the LAD back into the left main, and then kissing again. And actually, look at that circ expansion. That's one thing that has always given me trouble.
Yeah.
That circ. So I was actually pretty impressed with the result here based on that. Again, took our time. Was pretty happy about it. And then here's kind of the final angiogram of the LAD. Again, patient is in shock. So I'd say I take this result. I have TIMI 3 flow down the vessel, kind of flow to the RCA, and then circ flow again, and then maybe some collateral flow to the
Dude,
RCA as
that
well.
looks gorgeous.
Yeah.
All right, so patient's doing better. You've done a nice
Mhm.
DK crush. You
Mhm.
leave the Impella in. You try to take it out.
Yeah. So no, I definitely I kept this in, and then actually we ended up transferring the patient to a shock center. So again, this is another thing with the smaller hospitals. You can do a lot of great work in the cath lab, but it takes a whole village to really take care of these shock patients, from you know transport, nursing, ICU. The whole team really matters. So I think a lot of these patients that are really sick, until a team is up and running in a smaller place, I think it's best to transfer them to places where they're invested in shock. I mean, if you talk about a heart failure program docs, they have so many resources at their disposal, from either it's fellows or nurse practitioners or coordinators. There's so much stuff at their disposal. It's harder to manage. I mean, you know, me rounding at a few different hospitals or going to clinic and seeing this patient once a day, that's not the right thing
Yeah.
probably for the patient aftercare. So
Yeah,
I kind of focus on it like there's a few different stages for these patients. This is the initial presentation, so we kind of resuscitate and stabilize, and then the next part is kind of bridging them to kind of whatever strategy they need.
So did they go to the floor and then to the other hospital, or did you send them straight to the cath
So
lab?
usually, luckily, we have these systems in place now in a few of these hospitals where you pick up the phone and there's an immediate like shock line. So this shock line actually activates a few important people, and the important people aren't the docs actually. Like the
Mm,
heart failure doctor cannot get a bed, right? But you have a whole coordinator and a team in place that says, "Oh, there's a shock case in this smaller hospital. Well, I'm going to make a bed. I'm going to call the case manager. I'm going to get someone to put that order in." So these transports have become a lot more flawless, not flawless, but a lot more smooth because they get the right rig, the right ambulance, the right people come. So it's really, really has streamlined this patient population.
is it an auto accept, or do they just create the bed fast?
It's an auto accept, and they can create the bed. They can create the bed fast if they need.
And then is it a CCT ambulance that has to take them to the other center, or does someone have
Yeah,
to be
we call it the big rig. Yeah, it's the big
got it?
rig, either with the Impella or the ECMO, because that has happened in our trials and tribulations of these programs. They sent the wrong ambulance, then you wait another 2 hours.
Dude, I
Mhm.
mean, this is a huge problem nationally. You have all these rural centers that do primary PCI. They don't do a lot of outpatient PCI. So they have sicker patients because it's rural. They have staff that is not as facile with stuff as they are at big centers. And you don't have enough tools. So I think what you did with this patient is perfect. You had a great cath lab result. You had all the tools you needed to save them at that time in the cath lab. And if they have to escalate to ECMO, they're at an ECMO center. So
Exactly, and that's the thought process. A lot of times, again, in the beginning, a lot of folks were talking about, "Oh, why are you transferring this patient? We can manage it." I was like, "Well, what if they decompensate, and then you don't have an exit strategy or a next backup plan?"
and the nursing's never as good at the rural hospital, so they're uncomfortable with the
It's just
environment.
harder. It's harder. We're working on it, but again, because at some point they're going to need to manage these patients for a few hours. It's going to happen,
Yeah,
but
yeah,
it is challenging, and again, it's the resources aren't there. That's the hard part.
yeah.
Mhm.
Dude, this was such a great result, Arvin. I think it brings up a lot of important points that we deal with every day, which is, shock, complex PCI, calcium, managing your hospital system. So really good result. And how'd the guy do? Do you know?
Yeah, he was actually discharged. He had, recovery was a little longer, but after a few weeks, he actually was discharged to rehab, and then home later. So
Got it.
yeah,
Last question. What kind of Jordans were you wearing during this case? And how did
these
you
were the
figure
sixes.
it
The
out?
sixes I was wearing. Yeah, yeah. But Walsh, I wanted to bring up one other point that again, I'm really grateful that we actually had Shockwave to kind of achieve these results, because if we just had balloons and stents and NC balloons, again, a perf in this guy is just, it's a death.
Yeah,
It's a death.
totally.
So
Totally.
again, I think I've started noticing that I'm doing that a lot more, just aggressive lesion prep before even putting the stent in, and
Well,
I'm
dude,
happy.
and to your point, no one wants to use Rhoda in this situation.
Oh
Like when
no,
you have a patient with an acute STEMI who's in shock, Rhoda's a pain in the ass. Sometimes you have to use it, but Shockwave I do think is a little more elegant strategy. And as long as you can deliver it and you get good pulses, I think it's a great
He's-
option.
another one is less drama, more gains.
Yeah, I like. So litho lament and less drama, more gains, and
Yeah,
Air Jordan 6 for STEMIs.
there you go.
Got it. All right, brother.